Thank you very much. Ladies and gentlemen, good afternoon. This is Manos Brilakis from Minneapolis Heart Institute, and it's a great pleasure today to have with us Dr. Alfredo Galassi, who is one of the best CTO operators in the world. He is the president of the Euro CTO Club, and he has performed CTO interventions all over the world with amazing results. So we're very privileged to have him today present some fascinating cases on using the dual lumen microcatheter, which is an excellent topic, especially for US-based physicians, since we have less experience with using this technique. And before we get started, let me just remind that we thank the Abbott Vascular and Terumo for their support of this webcast. So, friend, again, welcome, and thank you very much for presenting to us today.
Welcome to you, and thank you to join this complex core intervention webcast, and it's a pleasure really for me to be part of this platform, which I really think that nowadays should be more and more the way of communication between people around the world. Today I'm going to give you some idea of how important is the use of dual lumen catheter in CTO PCI interventions. Before that, I really would like to say that, of course, I do not have any financial interest and arrangement or affiliation with one or more organizations that could be perceived as a real apparent conflict of interest in the context of the subject of this presentation. And I would like to give you some estimates of our club. And it's a really great pleasure for me to introduce the data that we showed in Krakow 2016, just 2 weeks ago, on the number of the club membership around Europe. As you can see, we are growing significantly, and during the last year we have more associate members, which are, of course, as you know, are younger members that basically are participating in the club basically as a first step as an associate member, and then they will get more as a full member after some criteria that, of course, represent mainly the number of procedure and expertise and dedication to this kind of complex procedure. This is more or less our sort of map of club membership, and you can see that basically different colors are basically representing either they are full members or coordinators. In yellow, we have full members in green, and we have associate members. But it's interesting to observe that the spread of the members are more or less even among all European countries. This is basically the numbers about the full member of the club, and we can see that more or less we have around 2,500 procedures per year, and more and more people in the club are mainly 95% operators who are dealing with retrograde and antegrade procedures. So this is very interesting that during the years, of course, nowadays, and I would say that in this year, almost all full members are basically dedicated to retrograde procedure as well as antegrade. These are the numbers of the percentage of approach, basically according to the retrograde antegrade procedure, and you can see 35% of the full members are using a retrograde approach, and 65% are using only antegrade approach. And these are the number of success, which is more or less stable above 85%, and of course antegrade success is antegrade approach is more successful than retrograde approach, but of course we deal with retrograde approach with more complex lesions than antegrade. Interestingly, complications are below 1%, and the only exception is for coronary perforation, which are, of course, considering the fact that we are increasing retrograde procedure, are increasing more than 3%, but still of course, these coronary perforations are not really some complications that we can deal, especially nowadays with many devices, and among them the devices which are mostly used are the coils, detachable coils. So going back to our main issue is basically the topic of dual lumen catheter. we have, of course, different Branden types. And here we summarize mainly the most used types of dual lumen catheter, at least in Europe. This is the new NHancer RX from EMDS. This is the called Fine Duo from distributed from Terumo, which is basically the old Crusade from Kaneka. And this is the Twin Pass from Vascular Solution. As you can see, among the three, not much difference regarding the type of dual lumen catheter, except for the probably the crossing profile, which is slightly better for NHancer RX, 0.75 millimeter. We have the Fine Duo 0.97 and 1.0 for the Twin Pass. Also,
here, if I can say quickly, so in the US, we only have the Twin Pass. So it's only for the US audience. Unfortunately, the only one we have is the Twin Pass. And then just to clarify for the US audience, Freddie, so is you said the Crusade and Fine Duo is the same thing?
Yes, I mean, all of them are mainly doing the same sort of principle. They're using the same sort of principle. They have, of course, the OTW channel and the RX channel. And so the two wires are basically getting one in the RX from the top, from the distal tip to the more proximal part, and then the other one, of course, is the crossing of the OTW channel. So as you can see here on the left, getting the wire from the distal tip of the microcatheter, you get the RX, of course, from here, and then of course the other hole is represent the hole where the OTW wires get out. And this permits basically from here, of course, permits you to have both wires, one RX and one OTW wires at the same time in the same microcatheter.
Wonderful.
The differences among the two devices are basically regarding the problem of mainly of the probably the distal shaft stiffness, torque response, in vitro crossability, in vitro torque response. As we can see from this slide, probably comparing the NHancer RX to the Fine Duo, the X Crusade, we have the distal shaft stiffness is much softer for these new devices from the MDS. Torque response is much better, and this is also related to the fact that he has got a small stylet inside the OTW channel, and it can, of course, can be removed when the RX device is advanced. In vitro crossability tells this device to have a little bit better performance as a crossability and even a better torque response. But of course, these are data on file of AMDS, so maybe that some of these data, of course, are compared on this company. What I would like to say that, of course, in this regards, this device has got, of course, a tapered through distal end visible, and this is very important. And also the more important is that OTW distal lumen direction, lumen exit is really you can identify on the side of the main lumen the distal end of the direction lumen exit, and this is because of the side marker that is just offset from the main catheter.
And Freddie, quick question: is that right is it like at the market, or is it more proximal? Like the Twin Pass, usually the exit point is a little more proximal to the marker.
Yes, more or less, the three devices are very similar. The marker is just before the end of before the end of the distal end, but more or less probably the Fine Duo from Terumo is a little bit shorter. The distance is a little bit shorter, and this NHancer EMDS NHancer is more or less similar. More similar to the Twin Pass, so a little bit more the length from this OTW exit and RX and exit are probably a bit longer, a bit more far away from as compared to the fine duo. But I will show you some of the cases, and I think we can appreciate the differences among them. First of all, of course, the most important issue is, of course, related to the use when it can help. And I would say that probably if in the past I was thinking that it might have been useful to use a dual lumen catheter in some CTO interventions, I must say that more and more I use, I would say, largely in my experience. And this is basically a sort of slide that represents in the antegradely approach how can we use the dual lumen catheter. One of the situations, of course, in the pre-canalization, and these are the two situations that we are usually using these dual lumen catheters. One is the new parallel wire technique, using this dual lumen catheter, and the other one is the dual lumen guide technique. I will show you for each of these specific situation a case. So we will go through. Another one is the post-recanalization. Of course, after the recanalization is made, we can use dual lumen catheter after either single wire or ADR techniques because it helps for recrossing branches distal to CTO, or for treatment of bifurcation lesion by double stent technique. And again, I will show you some case. So going into the details, let's see this new parallel wire technique. As you know, this is basically the way of using in the past wires. We were using wires that have torque whip response. It was basically wires that we were not able to control the tip in tortuous anatomy. And as you can see from the jump of the tip of the wire, this jump is a brisk jump, which of course needs in the spine a lot of maneuvers from the proximal end, a lot of expertise. The new wire without torque whip are basically those wires that are coming from side, and that are basically the wire that we are using. That are the new wires who have dual coil structure, and of course both Gaia and Fielder XTR XTA and also the Sion wire do have this double coil structure, especially for Gaia and for Fielder XTR and Fielder XTA. These allow a more, you see, progressive directionability of the tip of the wire, and this of course is a basically linear torque transmission, which of course makes the process much easier. You can see here on this graph what does it mean with motion when we compare all generation wires like Ultimate, Miracle of the same family of the SI wires versus the more recent wire with double coil structure, like as we can see here the XTR, XTA and Gaia family. And you can see that the distal tip and the proximal end are moving along a very stable identity line as compared to the previous brisk and sudden movements of the old wires. Indeed, in experience of the club, they are the most used wires, and as you can see, during the last years, 2015, this is increasing significantly for both XTR, XTA, and Gaia. And also, if that was the wire to start with, this is the wire that to go through, you can understand how important are these wires for getting success. Now, this is a typical example where basically we can use both these new generation wires and the dual lumen catheter. Unfortunately, the images are not so excellent, but this is only this first case. I'm sure that the next will be better. We have here CTO of LED with a short sort of lesion, a good stump, of course, no entry, no clear visualization of the entry, proximal entry, and we can see that basically going with the Corsair and Gaia wire, we are trying to redirect the wire through the distal CTO, distal cap of the CTO. What is interesting that after a little bit of an attempt, the wire gets into subintima, and even if we were trying to redirect, you can see that the wire is basically going outside of the identity line of the actual through lumen. So the idea in this case was basically to leave this first wire in place using a dual lumen catheter, and to advance through, of course, the other exit distal end of the catheter, the other wire, which is again another Gaia second, and to redirect the tip of the wire inside the true lumen. And basically, it helps you to keep the first wire in the subintimal space, and the second wire to maneuver the second wire through the true lumen of the wire. This is basically what we called a sort of new parallel wire technique, and uses basically, instead of dual lumen guiding catheter, just one single dual lumen catheter. And of course, it helps you a lot to redirect the wire into the true distal lumen. Another
devil's advocate. So if you have already a catheter in there, microcatheter, what is the advantage of doing the dual lumen versus a second microcatheter? And what is when would you do the one versus just get another Corsair or Turnpike and try that way?
Okay, this is a very important issue. Probably, and it's a very important question, probably I would use this dual lumen catheter and parallel wire technique using dual lumen catheter when I would really think that using Gaia, I'm really very close to the inner part of the true lumen, and I might keep through the movements of the wire a better stabilization of the first wire. Of course, this is an alternative to the standard double lumen microcatheters old strategy, and is only basically maybe used mainly when we really want to save materials, and probably when we think that the CTO crossing is not too long, and probably in a situation where basically we are very close to the inner part of the lumen. Of course, probably is more and more on fashion since we have these double coil wires, because we are probably able to maneuver better these double coil wires like Gaia as we were doing in the past. So probably I would say that if we use the old stiff wire with the whip motion, probably double microcatheter parallel wire technique may be still the preferred one. And as compared, if we use the new double coil wires like Gaia, and probably in this situation we can save one additional microcatheter and use only the double lumen microcatheter. But of course, much depends also on the situation, the actual space where basically this double lumen can adjust. If we have a big vessel, probably two double microcatheter may be used, when if we have very small space and we are sure that we are very close to the inner part of the lumen to re-enter, probably just one double lumen catheter may be used. I don't know if I answered to your question.
Perfect. So the smaller the space you have, the more likely to use this one, because it gives you a tighter profile, essentially less hematoma presumably, and higher likelihood of entry.
Of course, this is very correct what you say, but also we have to keep in mind that also very important is to maneuver with the double coil wires, because double lumen coil wires have, of course, different characteristics, having no whip motion. Another sort of application is called the dual lumen guided technique. I will show you a live case. I will take out the sound. If I take the sound out, can you hear me?
I can hear you. I can hear you fine.
You can hear me? Okay, so this is basically a situation where we have LED, CTO LED occlusion, and basically we have no clear visualization of the entry of this LED, and basically this can be basically a sort of a different way of using the Ibus guide technique. We call double lumen. In this situation I use NHancer RX, so I call the NHancer RX lumen catheters technique. Is basically the way of trying to engage with the, as you can see, with the distal tip in the RX, which is of course in the side branch, and maneuvering the wires, trying to find a way to get into the small channel of the entry point. This is basically done, of course, generally speaking, with the soft polymeric wires, and this is a typical example that, of course, you need still to have some probably micro channel, because that will, of course, facilitate the entry of the second wire. But typically, I mean, the wire is placed in the distal, of course, side branch, and you can play with the second wire, trying to get into the proximal cap, and this makes also the situation more stable, because of course you can put some pressure, as you can see here, and advance the device a little bit more distally in order to advance also the second wire. Okay. Here you can see that the advancement of the wire was even further. At that stage, you can remove the dual lumen catheter, and of course, you don't need that anymore, and you just place the new single lumen catheter, and you can, at that stage, redirect your wire according to the strategy. In this situation, we were able to use a caravel, because it was a very tight stenosis, and we were able to use this caravel and to push this filter XTR in order to re-enter through the more distal part of the artery. Maybe you can see here this next advancement. Yes. Okay, you can see now that the wire is getting through, and this was basically the most difficult part, was to get through the proximal part. But then once you got, of course, the proximal CTO entry, then of course everything gets much easier, and then you will see how, of course, you can maneuver filter XTR gently. Try not to, of course, dissect, and to get in the more distal part of LED. Okay, then this is the, of course, we changed then with the corset to increase the opening up of the proximal part. Okay, and then of course this is the full reconstruction with the stent. Okay, after 3 days implantation. This was last case in our Retro Summit in Vienna, and that's it. Also, any questions? Any?
No, I think it looks very good. Thanks, Ray.
Okay. So the other thing, of course, which is of course additional advantages, is the post-recanalization, and this, of course, is a situation where basically we have. We can have either a single wire or even after adhere techniques, and of course in adhere techniques we have a lot of channels, and this becomes even more complex. This is a situation of a very young guy with no previous MI. There is here basically a sort of revascularize and basically sorry for the phone, and basically thrombose and recanalized vessel. You can see that we tried with, of course, with Corsair and Figure XTR as a first line strategy. Figure XTR, as I told you, is the most used wire in Europe to start with, and 50% of this wire is getting 30% of this 50% employment is getting through. And here you can see that the wire is, of course, navigating in the proximal part, but then is stopping at some part of the CTO occlusion. And here you can see that is basically we are preparing now for antegradely dissection re-entry, which of course you can appreciate by the distal bend of the tip. And of course at that stage you have to put pressure. You can see the pressure because there is some disengagement from the guiding, and putting the pressure allow you to re-enter the more distal part of the artery. And this works, as you can see, on some branch here. And then it works in a way that basically it seems to be recanalized, of course, the main circumflex lesion. But of course, this is not just the proximal part, but then you can see we can have some balloon dilatation. I will show you what is going to be used next. Once more, the balloon dilatation. Once more, balloon dilatation. And of course, now you can see, you can appreciate by the injection that there is a lot of dissection here. And of course, the most interesting part is to recanalize, of course, the marginal branch. So in this situation, we were using, again, double lumen catheter, because of course we wanted to use the first preferential dissection plane and try to re-enter into this branch. And as you can see lively here, it takes a little bit of time, but I think it's very important to understand how important it is in this situation to have the same microcatheter that it can be used for both things, for using the dissection plane and to re-enter with another dissection and re-entry strategy. And as you can see here, again, this wire is in the section plane, and then you push it again, and again in the section, antegradely dissection mode, we are basically regain the true distal lumen. And you can see that from the, of course, from the bend at the tip. So now we have basically dissection re-entry here, dissection re-entry in the branch, and this was made possible by dual lumen RX NHancer. And at that stage, of course, after removal of the dual lumen catheter, we know that both wires are in the same dissection re-entry mode, and after dilatation, and after, of course, visualization and kissing balloon dilatation, we can, of course, also got the last branch with the same technique. We are using in this situation only one single lumen, but the way of re-entering is exactly the same. Dissection re-entry by pushing a soft polymeric wires. In this situation was a filter FC. And then once again, balloon dilatation for the third branch, and then, and of course, then you can see that both branches are dissected at this trifurcation, and but then after reconstruction by Fordress drug-eluting stent, the carina and the three branches are fully open. And this, of course, was thanking to the fact that we were always in the same dissection re-entry plane. And I think that nowadays that we are using more and more antegradely dissection re-entry, this use of the dual lumen catheter is really very an important issue. And of course we have lost this small branch, but we were really very happy about this type of reconstruction by this antegradely dissection re-entry.
So you're really using it like a stingray in a way, right? You get into the
more or less, exactly, more or less like a stingray device that helps you to keep the first wire in the first plane of dissection and to re-enter through the same plane of dissection into the other branches.
And how can you make the direction is the right direction? Can you rotate the catheter to make it point towards the true lumen, or?
Okay. I mean, I will tell you later on at the end of my presentation, because this NHancer RX does have a knob that you can basically you can twist, and you can identify the marker on the side of the branch of the microcatheter, and so you basically you might have some hint in redirecting the wire. Most of the other times this does not really happen because of course it's sometimes difficult or complex, and anyway you are really very close, and then you pushing the soft polymeric wire, you will re-enter very easily. This is because the distance between the tip of the RX and the distal tip of the OTW are not so far, and allow you to keep the two, as we were doing in the parallel wire technique, very close to the inner part of the lumen. I mean, mainly, I mean, the use of dual lumen catheter in these situations are keeping you basically stable in one dissection and re-entry plane, and making, as you said before, allowing you not to have a lot of hematoma and a lot of dissection and progression in enlargement of the dissected planes.
Wonderful.
Then, of course, another issue is the treatment of bifurcation lesion by double stenting. I mean, this is something that, of course, we are more and more using when we have a bifurcation, like in a situation like that of a LAD lesion, where basically we would like to, of course, gain both branches. This is a typical situation where basically a young guy, 44 years old, you need to both get the two branches open. And of course, this was done with an antegrade attempt in this situation by Coronary and Gaia, but this was a failure. Dissection ended up of course, in getting the wire, just as usually happens when you have this kind of bifurcation, just in the middle of the two branches. So, of course, because of the young age, we did not want to lose this possibility, so we tried to use again this dual lumen catheter, and as you can see, we place one wire in the dissected plane of the side branch, and we redirect the second wire, of course, the OTW wire, as you can see, inside the true lumen. Then we have a dissection plane to the diagonal, true lumen in the LAD, and of course at that stage we need to reconstruct of course in this situation we reconstructed with the double kiss mini crush technique and 3 retrograde stent. We reconstruct the bifurcation. But in these situations, of course, this was possible because once again the lumen was small, it was a young guy, and of course not much calcification and were present, and the redirection of the wire in this situation by the dual lumen catheter was really very successful. So this is another example, of course, that you need to use this dual lumen for treating these bifurcation lesions. The second, of course, big setting is the retrograde approach. And in retrograde approach, of course, we usually use this, of course, after recanalization, mainly after recanalization. And I would say that, again, this may be possible after retrograde wire which enter the main CTO vessel. And of course, in this situation, NHancer, but of course, any dual lumen catheter is used to recrossing different vessels from that where retrograde wire is getting in. And this is an example that it may be applied to different branches. This is a typical example where basically we're rewiring the PD. And this is an example where basically we have a 51-year-old man with the long-standing breech collateral. We have here the retrograde collateral flow. We have, of course, the approach was retrograde, as I told you. We have an approach which was by the usual reverse cut technique. Retrograde wire is Gaia, antegradely wire by balloon, and then we were able to, of course, externalize the RG3 wire. And this is very interesting, I mean, because we don't know really how much is the dissection. Of course, we can assess this by iris, but what is interesting that we need to regain the other branch, because the other branch, of course, is vital for this patient, because we entered from the post-rotal branch, but we want to gain, of course, the PD branch. So once again, antegradely, we advance the dual lumen catheter, as you can see from this video, and then we redirect the new wire through the hole of the, of course, of the side branch into the PD, this time the PD. And the main advantage is that, of course, doing like that, we are sure to use the same pathway of the retrograde wire crossing. And of course, this allows also us, after withdrawal of the dual lumen catheter, to have the wire which is used for retrograde approach and the antegrade wire in PD, and to use these two wires basically for reconstructing the bifurcation. I mean, this is really, I think that nowadays, for those people who are using retrograde approach, it is really very, very common to use a dual lumen catheter to recross and, of course, to gain the two branches easily. And I would say in much less time, less contrast consumption, less radiation dose as compared to the past. Of course, this may be done also rewiring in PL. This is a different situation, more or less in the same settings. Again, it's a CTO two branches. We have the two branches clearly visualized here in the PL and the PD. Once again, we go young guy, and of course we are using the retrograde approach after an antegrade failure. And here we can see clearly the two branches and the importance of the two branches for a very young guy. And here there is a usual septal approach. In this situation, of course, we are doing the other way around. We are not getting into the PL from the PL, but we are getting from the septal. You see the wire goes in PL. Then we are able, of course, to go as usual by Sion and Corsair, and then into trying to get into in the occlusion. Of course, here we are still working with Gaia. And then Gaia went into the false lumen, and then we had to use once again Gaia third. So we are stepping from Gaia first to Gaia third, and then Gaia third, you see, is able to navigate into the occlusion to, of course, to externalize the wire as usual, and after that we are basically using now this externalized wire. Let me see if it plays, okay, with the usual externalization process and balloon dilatation. And then we have now the most important part of it, because we have a lot of dissection oriented, very likely to be, especially in this area of the more distal CTO part. We don't want to miss this opportunity to navigate in the same channel. So once again, we use the dual lumen catheter, as you can see here, and we are basically advancing the wire, which is, of course, the Sion wire, into the PL branch. And you can see here, very interesting, that we are able to navigate and to advance the wire very close to the carina. And this is a very interesting point, because as we know, treating bifurcation, we should be able to advance the wire more distal to carina as possible. And in this live case, you can see that advancement was very close to carina. And this, of course, is also assessed in this situation by IUS, where basically we have the two, of course, PL and PD branch, and we can see that, of course, the two wires more proximal are in the same channel. And then, of course, it is the final dilatation and the final stenting, and of course, the final reconstruction of the. In this situation, we use a stent crossover bifurcation treatment because we were sure not to have dissected the entry of the TL by the use of dual lumen catheter. And this is something that, of course, was made by the IUS assessment made at the same time. So as you can see, this device is really very, very crucial for retrograde approach. Another case which does not really interest the right coronary artery but LED, this is a case where basically we are rewiring LED and the diagonal, and once again we see from retrograde approach, this time taken from the right to the LED. Of course, as usual, we are externalize the wiring. We are able to advance balloon to open the, of course, the main proximal part of the LED, and then by the use of dual lumen catheter, once again we are able to get the LED, this LED. This is a very important issue. I have to tell you that basically the use of dual lumen catheter in this situation is very, very many times used, and allow you to make sure that the wire, despite entering a very first septal, may allow you to navigate into the more distal LED part of it. And this is, of course, vital, especially for retrograde septal use, LED septal use, when the first septal is used. Yes, this is exactly what we were talking before. As you can see, this is a knob in this device that can adjust the torqueability, and this is the marker, which is a little bit offset from the central line. And twisting this knob, of course, you can secure on the microcatheter. You are able to twist the entry or exit of the wire, of the OTW wire, and try to basically redirect the second wire, the wire which gets out from the OTW wire, from this entry in a more really friendly user technique. This is why probably I would say that I use more and more this NHancer nowadays, both for the profile, but both for the fact that you might rotate its proximal knob, and you can really adjust in a way similar to the old-fashioned system we were using in the past. It was really bulk. I don't remember now the name. Is the one that we were using to twist at the tip, to make the tip, to rotate at the tip. So this, I think, is really very useful tip and tricks of this new device. Also, another interesting issue is that the fact that it is more smaller in profile allow you to use the Nanto technique in case of a 7 French guiding by this device, and this is because, of course, because of the smaller profile allow you to use this technique to redraw the dual lumen catheter from the guiding, instead of using the trapping balloon technique that is usually, of course, used in most of the case with old-fashioned dual lumen catheter. So I would say that I can conclude saying that the new dual lumen catheter are very useful for the complex procedure, and especially according to the friendly user. Its use, of course, determines increased procedural success rate, especially in the case of very complex dissection reentry, and allow you to reduce procedural time, radiation exposure, and contrast load. Of course, this device do have a cost, and this is an additional device cost that might be really counterbalanced as less material is employed during the procedure. And I really say that this not only less material is employed, but better performance and better result of the actual procedure is obtained, making sure that your wires are very close to one antegradely section reentry planes or in true lumen, distal lumen pathway. Of course, this at the end is making for you reduced cost and reduced cost benefit ratio, especially in complex CTO procedures. So I really, in my experience, I'm using more and more these devices, and I'm really finding this device very important, especially for retrograde approach, but not only, but also for antegradely approach in the case of antegradely section reentry mode and bifurcation distal branches.
Thank you, Freddie. That was an amazing overview of how to use this catheter. And again, we don't have much experience here in the U.S. I think partially because people don't use pearl wire technique as much. But I have a couple of questions that came through during this time, if you don't mind going through them. The first one is regarding exchanging. So let's say you crossed it, you got your side branch wire through there, and then you mentioned in one of the slides that you can use the Nanto technique to the contrast injection with the balloon. Now, aren't you worried with one of the other lumens about losing one of the wires when you do that hydraulic exchange?
Well, I mean, I'll tell you something. I mean, of course, it is safer to use the trapping balloon technique. It is possible to use this Nanto technique with only with NHancer RX because of the smaller profile, and only if secure the wire, the second wire by a spring soft wire, and you have a retrograde wire into the main shaft. This situation make the Nanto technique safe and possible. All other situations except that are not really advisable, because as you can understand, the wires, especially if you use polymeric wires, may slip outside. So I would not really suggest. But if you have, once again, a retrograde wire which secure one of the two shafts of the lumen catheter, and in the other branch a spring soft wire, this device can, the NHancer RX, at least the one with a smaller profile, can be taken out by the Nanto technique.
Wonderful. And then another question that came through is regarding once you cross into the side branch distal to the distal cap, and then you're trying to cross into the main vessel using the dual lumen microcatheter, do you use a polymer wire or a soft wire? What wires do you typically use to avoid dissections and getting into the main vessel distal to the cap?
Okay, this is a very interesting question, and I think it's very important. So, if I realize that I have not much disease and in the branch, and I must think that this new wire is getting into the branch easily, I usually prefer to use Sion wire, so hydrophilic wire, which can be mainly spring wires with hydrophilic coating, like Sion wire. If I am in dissection mode, antegradely section reentry mode, and I have very high likelihood of having a dissection also in the initial part of the side branch, I prefer to use a polymeric wire like Pilot, like Filter FC, the old Filter FC, which works very nicely, because I would really need a wire which with the polymeric coating is able to navigate into the small proximal dissection and re-enter easier into the more distal part, even because I might have the possibility to have again an antegradely dissection re-entry in the side branch.
Wonderful, wonderful. I think that was very, very useful how to use it. Once again, we'd like to thank you very much. That was an amazing presentation. I think also the slides you showed from the Euro CTO, they parallel very nicely the uptake of CTOs in the US. So I think a lot of convergence happening there as well. So again, thank you so much for an amazing presentation. Very, very useful to those of us all over the world who use these microcatheters. And again, I would like to thank the sponsors, Abbott Vascular and Terumo, for sponsoring this webcast series. And again, thank you all for being part of this series. Thank you very much, Freddie.
Thank you, Manos. Thank you very much. And thank you to the organization, the Compass Co-Intervention webcast.
Thank you. Thank you so much.